So now we move from palliative care to survivorship care. And it's my pleasure to introduce you to Dr. Tish Knobf, who holds a master's degree from here and a PhD in nursing from my old stomping grounds at the University of Pennsylvania. Her clinical practice with women with breast cancer over the past 3 decades has been foundational to her program of research. Her initial research study on the phenomena of weight gain in women with breast cancer on adjuvant therapy, published in 1983, resulted from the observed distress of women experiencing a change in weight. The concept of symptom distress became an integral component in her research. Description of symptom patterns over time has provided a foundation for evidence-based teaching and development of interventions. Her current research is focused on survivorship, addressing persistent and late effects of therapy and health promotion interventions. A psychoeducational intervention of physical activity and healthy eating for women of color who are cancer survivors has just been completed. She has recently completed an NIH-funded randomized controlled trial of aerobic-resistant exercise compared to a home-based physical activity program with bone mass, body composition, metabolic risk factors, and cardiovascular function as outcomes. She is also co-investigator on a cardiac risk assessment study for women who receive adjuvant cardiotoxic therapy for breast cancer. Managing risk factors for comorbid illness in cancer survivors is an important intervention target. Leadership in oncology nursing began early in her career, having been elected to the board of directors of the Oncology Nursing Society in 1977. She was 5 years old. Tish's contributions to nursing have been recognized through multiple awards, including the Oncology Nursing Society Excellence in Breast Cancer Education Award, the Yale School of Nursing Annie Goodrich Teaching Award, the American Cancer Society Bronze Medal, Distinguished Service Awards, and she was the American Cancer Society Professor of Oncology Nursing for 2 terms, of 5 years each. Her expertise has interdisciplinary recognition, and she's been selected to participate in national forums related to breast cancer. She will talk today about interventions to improve health outcomes for breast cancer survivors. Tish?
Thank you. I'm going to talk a little bit about the foundation for my interventions. First of all, the majority of my research has been with breast cancer survivors, so why is that important? So out of the 13 million cancer survivors today, over 2 million are breast cancer survivors, so really predominantly in the cancer literature you see a lot of breasts. It's because there are a lot of survivors, and it's a large population. And so how did I get interested after about 10 or 15 years of doing longitudinal descriptive studies, looking at the experience of treatment, the experience of women during treatment? We clearly were improving the outcomes for these women, and so now we were living with the recognition of persistent and late effects. So not only physical persistent effects, but also psychological, but also significant effects for long-term chronic illness risks like cardiotoxicity and bone loss. So this gives you a little bit of a snapshot of what I'm going to try and cover. So carrying on is a grounded theory study that I did, which I'm going to talk about because it created the entire foundation for my interventions. So the yellow are all the studies that I've completed based on the middle range theory of carrying on. And the pink studies are those that are currently submitted to NCI and will get reviewed this summer. So carrying on was a grounded theory study that I conducted to understand the experience of women who were dealing with 2 life events simultaneously. So a new diagnosis of breast cancer, and it was in an era where we were beginning to treat younger women, so we were also inducing premature menopause. So this is the middle range theory, and there are 4 stages. And actually now becoming menopausal, since this was published, I've actually used the literature and changed this to developing awareness and made this theory actually applicable to all survivors and probably maybe to several chronic illness models as well. But being focused very briefly is what's happening during therapy, facing uncertainty, and the developing awareness of what it meant to experience premature menopause sort of was a recursive process. But balancing occurred about a year and a half or so after treatment was finished. So this is the last stage of the model, of the theoretical model that really is the foundation for the development of my interventions. So balancing included staying healthy. These women wanted not only not to have their breast cancer come back, but they also didn't want to die of cardiovascular disease, or for my African American women, they did not want to have to deal with diabetes or hypertension. So it was about staying healthy as a woman. Being wary was about reading the fine print, not wanting to take risk, and this has lots of implications for pharmacologic versus non-pharmacologic interventions. And struggling with the system. This is universal. This is our silo, specialized healthcare system where you refer, and the referring providers actually don't talk to one another. So this was the first study we did. As Marie pointed out, you have to have an acronym. So EXCEL was Exercise Can Enhance Life. So this was a pilot feasibility. You'll see a pattern, Lois's work, my work, Marie's work, where you do pilot studies to, what I did there, to end that meal. I'm so glad you stayed. Okay, so that one I don't touch. Okay, thank you. So this was a pilot study, one group pre and post test design, and it was a 16-week supervised intervention with a weight-loaded belt. So for anyone, there are some gray hairs here. For once you go through menopause, you need an increased osteogenic stimulus if you want to maintain your bone mass. And so in this trial, even though it was a pilot, we thought that we would use weight loading to see if we could weight load the hips to get a better osteogenic stimulus from the intervention. We used 3 community fitness centers because we knew women did not want to come into New Haven. And we really just wanted to look at the feasibility and preliminary efficacy. So the mean age was 51, which is very representative of almost all the studies I've done in this area. Fairly well educated, and the primary breast cancer treatment is pretty common. So just briefly, in this feasibility study, it was feasible. We had a very high adherence rate, but it was a convenient sample, and it was pre-post test design. But the women did not gain weight, and this, against of historical controls, women tend to gain 5 to up to 20 pounds after breast cancer therapy. Depression, and this is going to be a theme, significantly improved over time of the 4 months, and using the short form medical outcome study, physical functioning, vitality, emotional well-being, mental health, and social functioning improved over time. So what did we learn? In the course of the studies, what happens to us, as Bernie mentioned, you know, your questions come from clinical practice, and then there's the historical effect of what happens when treatments change. So what we were finding was aromatase inhibitors are anti-estrogen therapies. They were becoming much more common to prescribe than tamoxifen, and they have a whole new side effect profile. We learned from the participants that there were unmet survivor needs, and by the time the pilot ended and we began our RCT, the Institute of Medicine came out with a report called Cancer Patient to Cancer Survivor Lost in Transition. So they clearly identified in the IOM report that we were not meeting survivor needs. Social support was really important. This intervention was conducted in 2-hour blocks, so the women often exercised together. But the women thought the 30-minute intervention was also boring. We needed to diversify it. And looking at the healthy postmenopausal women, we clearly knew that we needed a 12-month intervention. You need 12 months of resistance exercise if you're going to impact bone in a postmenopausal woman. So also at the same time, more literature was being published. There were several observational cohort studies suggesting that exercise could improve survival in breast cancer patients. And then also from the international aromatase inhibitor trials, we were learning that the bone loss was pretty significant, 2 to 4% per year, with an increased risk of fractures. And there was a greater use of trastuzumab, which is a monoclonal antibody against HER2/neu, and that was definitely associated with an increased risk of cardiovascular events, with about a 4% incidence of heart failure. So we cured the breast cancer, and now women with heart failure, we're going to see our colleague Jessica Coviello. So Yale Fit is Yale Fitness Intervention Trial, and this was a randomized controlled trial funded by the NIH, 12-month aerobic resistance compared to a home-based health promotion group. We used a home-based health promotion group because we felt it was unethical because of the national guidelines of, I'm sure you all adhere to them, 30 minutes of physical activity most days of the week. And so that was our home-based group. As many others have said, it takes a village, but particularly when you see my physiologic design, the co-investigators here are pretty critical in terms of their expertise. For instance, Carl is professor of endocrinology and head of our musculoskeletal bone center, and every person here has a particular expertise for the kind of either the testing we were doing or the outcomes. So this was a very pretty straightforward physiologic framework looking at those outcomes that I was concerned about for survivors. So bone mass, because we know induced menopause and the AI patients lose bone. Body composition since 1983 when I published the first weight gain paper. It's not changed. Women are still gaining weight. Metabolic risk factors, new data were coming out about insulin resistance in breast cancer survivors. And then functional status, particularly cardiovascular fitness. So this was the intervention group. It was supervised for 6 months, unsupervised for the second 6 months, and encouraged to have aerobic activity on most other days a week. We used community fitness centers again. We matched women where they worked and lived to community fitness centers to maximize their adherence, so they could choose where they wanted to go. And then the health promotion group was moderate physical activity most days of the week. Both groups got nutrition teaching, and of course, most of you know you need vitamin D and calcium for your bone health. So the target sample was 150. We over-recruited a little bit because of expected attrition. The mean age, as you can see there, was very similar to the pilot study. And you can see here the BMI, waist circumference means, tells you that 2/3 of this sample were overweight or obese. So they're really reflecting a lot of the population of women in this age group, unfortunately. So the only data we have analyzed so far are the bone outcomes, so I'm going to briefly present those to you. So unfortunately, there was no difference between the exercise group and the health promotion group on the bone outcomes. We are speculating somewhat because remember that the intervention was supervised for 6 months, unsupervised for 6 months. We know from our interventionists at the fitness centers that there was fall off in the second 6 months when they weren't supervised. The bone outcomes you can only measure at 12 months. So we think that might explain it, and we do have serum biomarkers that we collected at baseline 6 and 12 months, and we're hoping that the serum biomarkers are going to help explain the story. However, even though this is not going in the right direction, this is significantly less bone loss than what we know in clinical practice. So that's the spine. The hip has a very similar pattern, and the trochanter has a similar problem. So we asked ourselves, well, okay, how are we going to explain this after getting over our initial disappointment? And so what we looked at was endocrine therapy. We know that aromatase inhibitor creates about a 2 to 4% bone loss per year. We know that tamoxifen in premenopausal women is associated with bone loss. It's somewhat protective in postmenopausal women. And then we had a no hormone therapy group. So what was interesting was this pretty much fell out a third, a third, and a third. And so what this slide is a little busy, and I'll show you the summary on the next one, is that There was no significant, even though the aromatase inhibitor patients significantly lost much more bone, this analysis suggested that there was no difference between that when you're controlling for age, baseline bone mineral density, BMI, and vitamin D at baseline. And that controlling for those, there wasn't a difference between the AI therapy and the tamoxifen or no endocrine therapy. And there was no difference between the exercise intervention. So what we're concluding, and I have a colleague from Oregon who's published a very similar study, same kind of intervention and maybe even a little more resistance. And what we have concluded is that the exercise dose and the degree of the osteogenic stimulus to preserve bone in breast cancer survivors may need to be greater than healthy postmenopausal women. So walking alone doesn't help your bones if you're postmenopausal. You need impact. So for both of us, we both, Carrie and I, both had jumping jacks in the protocol. Well, breast cancer patients don't like jumping jacks. They have reconstructed breasts. They will not do jumping jacks. So jumping as an impact, we had to eliminate from the intervention. And while we had other interventions in the resistance component to put torque on the bone and create a greater osteogenic stimulus, it may not be enough. So several of my colleagues said, as Bernie pointed out earlier, African Americans make up about 12% of the population. So for every, for every newly diagnosed breast cancer patient, you see 10 new patients come through our breast clinic. 8 or 9 are going to be white, and 1 or 2 are going to be black. And so a lot of my colleagues said, you really need to look at the African American community as a separate issue, and why should we worry about their survivor outcomes? Well, they have a higher mortality for heart disease, cancer, and diabetes. And remember, in the theoretical framework of carrying on, women are worried about staying healthy, not just a cancer-specific survival. African Americans are more likely to be overweight or obese, although I think from the data from my FIT study, I think the white women are catching up. And similar to the white women, African American women tell us that they gain weight after therapy. And they also may be less physically active. And now, of course, we know that there's more cohort observational data suggesting a survival relationship. So we also know that we have disparities in survival. So if you look up there for breast cancer, you see that 5-year survival rate for white women is 90%. For African American women, it's 76%. So there are a lot of explanations, including now we know it's not just access, it's not just the mammography rates now among African American and white women are the same. So it's not just access, but it may be the quality of care that's delivered, so access doesn't necessarily translate into quality of care delivered. And also we know there's a genetic component. I took this seriously, and after about 6 or 7 years conducting a focus group study with African American women to understand their experience, which was called Connecting Sisters, we moved on to the next project, which was called Staying Connected, which actually at the time we were very happy to be funded by then a P30 center, which was a relationship between the Yale School of Nursing and the Yale Howard and Howard University. And we were able to do a community-based project, and this is reflected in one of our meetings in our old place, actually. We loved this place, but our old place was really nice to conduct inner-city research. And so during this, the women told us that they really wanted, similar to the white women in my initial study, they wanted to be able to stay healthy. And so then we applied for funding for a project called Healthy Sisters. So we went from Connecting Sisters to Staying Connected to Healthy Sisters. And this was to engage and empower African American women who were breast cancer survivors to adopt healthy lifestyle behaviors and to improve functional ability and quality of life. So it was a 6-week face-to-face psychoeducational intervention, 2 hours a week, with definitely individual goal setting. We had 4 groups. We were required by Lance Armstrong to have a community site. So we did 2 groups in New Haven and 2 groups in Bridgeport. And so these were the topics that we covered. And this concept of sisterhood, we actually operationalized the concept of sisterhood by one of our weeks. Every single participant created their own piece of jewelry. And it really was quite amazing. And then we had posters of every group, and every woman had an individual picture with her jewelry, and then also a group photo. It's one of the most fun studies I've ever done. So this was the physical activity component, national guidelines. We had an African-American exercise physiologist who did this part and worked with the women weekly. They could do any kind of exercise they wanted, but we did find out that it was predominantly walking that the women did. We had to teach them how to use pedometers. And the healthy eating, we used the American Cancer Society guidelines, which are identical to the ADA and the AHA. We used the Soul Food Cookbook, which is produced by the American Diabetics Association, because it has nutrition labels. And it was an important component of teaching the women how to read nutrition labels. So that's why we chose that. We then had to alter the intervention because we had several Hispanic women in our Bridgeport group and some mixed people, so we had to add in a Latino cookbook. And we used a dietitian who had experience not only with research interventions, but particularly with minority women. She's really pretty amazing. And the core to this was individual goals that we discussed every week. So there were 41 participants, 30 were survivors, and 11 were partners. We tried to incorporate the idea of partners to promote adherence. And we saw no difference between the partners and survivors and demographics, so we lumped them together. In contrast to my other studies, this age group was a little bit older. About half were employed. 52% had income less than $40,000, but they were fairly well educated. So this is just one of our outcomes. We looked at the Healthy Lifestyle Profile instrument, which has been used with African Americans, and it's a 52-item scale, so you can see their survivor and partner. And we did get an improvement for the survivors at all time points, but we collected data at baseline, end of the program, and 3 and 6 months, because you always want to know if your intervention worked at the end of the study, was there any sustainability. So I'm just now going to quickly show you some of the subscales. This was the health responsibility subscale, so we were really pretty happy about this. This was the physical activity scale, which I wish had a slightly better outcome, but it was statistically significant. This was the nutrition subscale, so although there was a fall off in 6 months, we were happy that at the end of the program, and even at 3 months, women had more confidence in being able to eat healthier. And this was stress management. And again, these were, all African American or Hispanic women had significant stressors in their life for the majority of them. So this was I think, a really important outcome for us, that this 6-week intervention really was able to give them a greater sense of being able to manage stress in their life. So in conclusions, I just want to highlight Diane Erdos was the project director for all 3 studies with the breast cancer patients, and Jean was really our Bridgeport person. She's a survivor, and she really helped us recruit with the Bridgeport group. Healthy lifestyle behaviors improved over time by self-report, and management of life stress improved. And it is a small sample size, but this was a very effective intervention for these women. So just to sort of end the concerns of women around wanting to stay healthy, many of the women in my early grounded theory studies said, I think my breast cancer is cured, but everybody in my family dies of cardiovascular disease early. And then over these maybe 10 years while I did these studies, there was more and more data about the cardiac toxicity. So now we know, one, that breast cancer survivors, because we've improved survival, die more often of cardiovascular disease. So it is a big issue for breast cancer survivors. So there is this multiple hit hypothesis that's actually proposed by Lee Jones, who was at Duke. And what he proposes is that what happens when the person comes into the breast cancer story? They don't come in de novo without any risk factors. So, and until we recently had our cardio-oncology clinic, none of the oncologists were doing baseline cardiovascular assessment. And if people have questions, I can talk to you about the Heartstrong study. But so then what happens if you come in and you have a little hypertension, or you're overweight, or you're a smoker, or whatever? And then we know that adjuvant therapy, we know that there's deconditioning and that there's potential cardiac toxicity that goes on. And in the next slide, I'll show you, review by Lee, that there's decreased cardiovascular reserve. And what we don't know is that this is the big question. What does that do to the long-term cardiovascular disease risks? So here was a publication by Lee and the oncologist who looked at 47 breast cancer survivors compared to 11 age-matched controls and showed that breast cancer survivors had significantly lower cardiac functioning compared to the age-matched controls. So what we also know is, even though Lee published this as well, this is the Yale Fit study, our confirmatory, that we know that exercise, if you look over here, exercise definitely can improve cardiovascular fitness in women who have completed breast cancer therapy. So we know that exercise is a good thing. So going back to Lee's hypothesis, I began to think, okay, if we know that treatment deconditions the women, that they end up with a decreased cardiovascular reserve, is there a possibility that we can intervene earlier, like Marie in her palliative care? Can we intervene earlier and prevent this decreased cardiovascular reserve? So I use the concept of prehabilitation, which is the earliest phase of rehabilitation, and it's designed to try and maximize and prevent adverse effects of treatment. To date, it's pretty much, you see some surgical studies with COPD to see if they could improve treatment. But I took the concept here to try and prevent the adverse effects of adjuvant therapy and proposed a 16-week lifestyle intervention, which is a phone intervention using Kelly Brownell's Healthy Lifestyle Learn program, which is a coping skills, motivational kind of thing. And we would recruit women prior to neoadjuvant or adjuvant therapy, and the goal is to prevent deconditioning. Fatigue is a huge issue which contributes to the deconditioning. And this was submitted to the NCI in February, and hopefully will be favorably reviewed this summer. But I think my presentation, as well as I think all the ones that have come before me, have really addressed the YSN mission of better health for all people. So thank you. So do we have time? Oh, okay. So I could have talked slower. Marie.
So I want to ask you about the partner's role in this. So you've done some studies with the partner being involved. Do you think that that's a critical ingredient in success of women maintaining, or what do you think about that relationship?
The only study I used partners was the African American one, because we knew that most of these women were coming from the inner city. We had lots of discussions about how they were, and it was a home-based program, like what were the safe neighborhoods, where were they going to work, where were they going to walk, and we just thought that not every breast cancer survivor would be able to have another breast cancer survivor as a partner. We also thought that for some of these women, they might do better if it was their neighbor or somebody else in their house. A couple of the women in the Healthy Sisters Project, used either neighbors or a daughter or a sister, something like that. And then there were some partners that didn't participate in coming to the classes, but many of the women also used spouses to try and get the spouse to walk with them. And the partners, I think one of the things that, sort of qualitative data, that when we haven't published this yet, was the benefit of the information around physical activity and healthy eating. So many of the partners also were able to take that information back to their families. So they were dealing with the same kind of concerns. being overweight, worrying about developing diabetes. Some of them already had impaired glucose tolerance. Some of them already had hypertension. And if they didn't, somebody in their family did. So, so that was the only group where we used partners. In the large randomized controlled trial, we used the concept of social support. So what we did was we had, again, the blocks of time. So we had 4 days a week with some flexibility, but we found out from the women what would work best. So the majority of our blocks of time were 5 to 7 because women wanted to come right after work. And then we had one morning group for women who either didn't work or they had flexible schedules. They prefer to go in the morning. And we tailored that depending on which fitness center we used. So we used the concept of social support for adherence there. So what we're doing now is we're trying to look at, thankfully for one of the reviewers, they made us collect physical activity data on both groups, which we use the International Physical Activity Questionnaire, and we tried to collect monthly data. So this collects not only, it collects all your leisure time activity as well as moderate and vigorous activity, and you can actually also calculate METs from it. So we have that data on both groups, and we're right now looking at it, and we haven't looked at it with adherence to the gym yet. And we only have adherence data to the gym in the first 6 months. But what we have seen as preliminary data is that the level of physical activity skyrockets in the intervention group from baseline to 6 months. And then it falls off 6 months to 12 months. So I think our hypothesis from our interventionists are correct that the women in the gym, Dana wasn't there to meet them, they sort of fell off. Whereas the home-based group, their level of physical activity was almost flat from baseline to 6 months. And then it increased from 6 months to 12 months. And we have not yet been able to explain that. We are thinking that they came to the hospital research unit at 6 months for their data collection. And maybe they thought, well, maybe I should get my act together and really, we can't explain why at 6 months the home-based group improved their physical activity. There's still a statistically significant difference at 12 months between the two groups, but it's dramatic at 6 months, and then it's less at 12 months. Or the other hypothesis from some of the study team is that because the home-based group had to integrate this in their own life, maybe it took them up to 6 months to really figure out, how am I going to do physical activity every day? How am I going to make this work? How am I going to stick to a schedule? I don't know. I'm not sure if we're ever going to be fully able to explain it, but...
Was time of year, being that we're talking about New Haven and Bridgeport, could that have had an impact?
Oh, in the small group?
Being difficult to get outside.
That Healthy Sisters went over 2 years. So I don't know. But in the randomized control trial, we were going to try and look at time of year. But we recruited 154 women over like 3.5 years. So it was pretty much an ongoing kind of thing. But even with the home-based group, similar to Healthy Sisters, we had a printout of all strategies that they could use if the weather was bad. Going to a mall, and we also identified there are several high schools that have indoor tracks that at the end of the school day go to the local recreation program, and there was one really close to the School of Nursing. So we identified all the high schools that had indoor tracks where they could go, and things like that, and strategies to be able to get 30 minutes of walking in every day. Ani?
So this is my last semester at YSN, and we really excited. But my classmates and I wrote a proposal for a project actually, which was chemotherapy-induced heart failure and a prevention project. And I wanted to throw the idea, maybe use it or implement it in where you work, but we were kind of selling the idea of identifying the high-risk patients who are about to start chemotherapy and get a cardio-oncology NP or the cardiologist involved early on to do like baseline echo and EKG.
Right. So it's a great idea. It's an exploding field. It's probably about 5 years now that there's really been this emphasis on cardio-oncology, and the earliest programs started out at MD Anderson and Vanderbilt, and they've now each had 2 annual cardio-oncology conferences. And a year and a half ago, NCI and NHLBI teamed together and had an invitational conference looking at cardio-oncology and looking at the state of the research. And so it's really in its infancy. So now at Smilo, we have a cardio-oncology clinic that started a year ago. We have a cardiologist. We have Jessica Coviello, who's on our faculty, who's an NP there. And we actually wrote a couple of proposals. So the problem right now of trying to identify the high risk is that we really have not had large-scale randomized controlled trials to look at what are the markers for subclinical disease. So for those of you in cardiology, you know that left ventricular ejection fraction, if that falls, all right, it's history. It's telling you that the damage has already occurred. So, that's really not, even though that's the marker everybody uses throughout the world, is to look at ventricular function in terms of risk. We're trying to look at what are the subclinical factors. So we are looking at troponin and BNP, but there's a lot of variability. And then the newest thing that was at this conference is looking at 3-dimensional echo, because now it's looking like maybe it's not just the left ventricular ejection fraction, but maybe it's a longitudinal strain that might give us more information about who's developing cardiotoxicity so we can intervene earlier. There are a couple of trials from Italy that are looking at ACE inhibitors, prescribing ACE inhibitors if somebody has a spike in their troponin. But it's a one-site study, was highly criticized at this NHLBI meeting, that we really need multi-site randomized controlled trials looking at these. Also, there's some more high-sensitivity troponin assays that are available in Europe that are not available here yet. So that's another issue. So you're going to hear a lot more about cardio-oncology. And so we implemented, it was Jessica's project, implemented a standardized cardiac risk assessment in our cardio-oncology clinic, and have gotten our medical oncologists in the breast center agreeing to refer all the newly diagnosed breast cancer patients to the cardio-oncology clinic prior to their starting the chemotherapy. And we've got the cardiac risk assessment integrated now into EPIC.
I just wanted to add too, for us, we were trying to sell the idea, and part of it was the Affordable Care Act's CHF readmission restrictions. And so for us, we were saying, if you wanted to use that, we just thought that was kind of brilliant. We're like, oh, we can save everyone a lot of money if we just done all that. So it's just another idea.
Bernie?
Is there, when there are the detriments in EF, does it cycle back up?
Not for chemotherapy. The chemotherapy and the targeted therapy, so trastuzumab is a monoclonal antibody against HER2/neu. That, in some patients, is reversible. But we know that there are a very small percentage of the trastuzumab patients that will have persistent defect or persistent decline in left ventricular ejection fraction. In chemotherapy, it's direct damage to the cardiomyocyte. So it is not, they may, if you were at 55 and you dropped to 45, could you go back up to 47? Maybe. But it's irreversible damage to the myocyte from the chemotherapy. But if you combine the chemotherapy concurrently with the trastuzumab, the cardiotoxicity incidence really increases. So most people don't do that now. They do it sequentially. So they'll give the chemotherapy first, and then they'll start the trastuzumab after the chemotherapy's done.
But you said that you're implementing a risk assessment, a cardiac risk assessment, and that there's some way that you might be able to identify these patients at high risk who might be going into this therapy with an underlying hit secondary to their risk, right?
I don't know if we can identify them as high risk for the cardiotoxicity. What I think our risk assessment is going to do is identify cardiovascular risk factors, which we've not done before routinely in practice. So when we did our cardiac risk assessment, HeartStrong longitudinal study, Jessica and I, the major barrier was getting fasting bloods, because our medical oncologists never do fasting bloods. And so that was a major barrier to that trial, which we finally overcame. So I think we're going to be able to identify cardiovascular risk assessments, and then we have built a database in the cardio-oncology clinic, so we will be able to use the risk assessment in the database, hopefully being able to mine the data out of EPIC, which is a big question, to look at their outcomes over time. Because the cardiologist has built a nice database.
So here's something to consider. One of the issues with cardiac disease, because it's something that does this, right? You start to fail and then you go into stages, and you're in stage 4 and you've got end-stage heart failure. But one of the issues is endogenous catecholamines, which people don't like to play with because they're fleeting. So you've got them flying because, you know, the fight, flight kind of stuff. But the issue with that is, that I'm struck as I'm listening to you, the issue is that you get these catecholamines, they come out because of stress. So the HPA axis associated with kind of psychoneuroimmunology stuff. The worry about the constant bombardment of what's happening to me, what kind of drugs are going to happen to me, am I going to die? All these things that are going on in people's heads are driving endogenous catecholamines, period, baseline. So the higher that environment goes up and the level goes up, it actually impacts the beta-2s on the outside of the contractile fibers of the cardiac muscles, because you guys are constantly looking for troponin leak, is what I hear you saying. But what I'm saying is that the disease process and the psychological piece of the disease process are probably driving the endogenous catecholamines in addition. So for those people who may not, by a verbal risk assessment, maybe they don't show up to have heart disease, but physiologically, they're set up to have heart injury. And then on top of that is the hit from the chemicals that you're giving. So you've got it. So I'm suggesting biomarker. Like if you're going to get blood, get some blood, freeze it, let it sit there, and then get the catecholamines, because you probably have a bad actor happening secondary to the HPA axis, period, just related to the stress of the cancer and the, you name it, you know it better than me. And that is one of those precursors to what you think you're getting. Because if you're following the concept that this is that there is some kind of pre-hit, and we're going to use that pre-hit by standard diagnoses, maybe we don't. Maybe it's really the disease itself, this whole cancer thing, because of, you know it better than me, fill in the blank that happens over time.
Right.
And the thing is that the patients don't go through this cancer by themselves. They have the stress of the family. They're sitting in clinic with a foreign person, and they're looking at that person. So there's a lot of stuff I think they take in that cancer process that's driving the catecholamines.
The other big issue is the dynamic changes in the treatment options now with targeted therapies. So we have all these anti-VEG and these other kind of monoclonal antibodies that we know, if you look at the pathways, are also the same kind of drugs that are interfering with other organ systems. And while they might be curing the cancer, I think we're, causing other problems. I mean, Avastin is a huge issue. I mean, hypertension is the dose-limiting factor with Avastin.
Please don't stand.
Okay.